With us is Dr. Michele Tagliati, who is our expert today. He's a neurologist and a movement disorder specialist serving as the director of the Movement Disorders Program at Cedars-Sinai Medical Center in Los Angeles. He is one of the nation's leading research and treatment specialists, and he's been in practice for over 20 years. And if you guys have been on the website or if you saw our earlier program, he actually came on and did a talk for us on REM sleep behavior disorder. So today he's back to talk to us on an initiative that he's been very passionate about and has been working on in regards to digital monitoring. So I'm going to hand this over to you, Dr. Tagliati.
Thank you. Let me just share my screen. There we go. Let me see. Can you see the title slides? Perfect. Thank you, Anissa, for this beautiful presentation. And a quick disclosure: much of the data that I'm going to present refer to monitoring patients with diagnosed Parkinson's disease, but the key, as we will see, is about monitoring a progressive disorder. So the concept can be applied, obviously, to the early and premotor stages, and I welcome eventually questions or discussions more specifically directed to that stage of the process. So one very important consideration, the starting consideration for this talk is that our modern, amazing, miraculous medicine system is built, if we think about it, to excel at acute care. So if we have a heart attack, if we have a stroke, if we have an infection, if we break our leg, if we have something that came to change immediately in the short term our well-being, we can go to the emergency department where we're going to be triaged with incredible speed, efficiency. TV shows have been obviously popularized the work of emergency room. The patient goes through the system. Protocols are incredibly efficient. They run fast. Time is imperative. You know, within 30 minutes, we need to apply certain medication or get to certain surgeries. And once we define the problem, we have our focused intervention and an outcome. And if all goes to plan, the case is closed. The problem is solved in most cases. This is all fantastic, but it doesn't fit to a chronic disorder like Parkinson's disease. Like many other neurological conditions, is a chronic problem. It's a progressive problem that can unfold over months, over years, definitely not days or hours. And he has many different symptoms, sometimes different from patient to patient, that interacts. They may fluctuate from day to day, sometimes from hour to hour, and it doesn't resolve, unfortunately. We don't have a cure, we don't have a fix. And so at best, we can stabilize it and hope that it will stay put, at least for the foreseeable future. So our episodic, spotty checks that we use to treat, to follow on patients with Parkinson's disease and similar disorders is extremely inadequate, because Parkinson's disease is a continuous problem. It's not an episodic problem. And so physicians are often forced to make decisions based on very, very approximative and inaccurate information. In fact, the reality is that Parkinson is a complex disorder with motor, movement problems, and non-motor symptoms, sleep, blood pressure, cognition, etc., with sometimes as short as hour-to-hour fluctuations, and very context dependent. You know, whether you're stressed, whether you slept well, you didn't sleep well, whether the environment is helpful or stressful. But what we do, what the medical field does, it brings you in, every 3, 4, 6 months, maybe even longer, for a 15, 20 minutes exam, maybe 30 minutes, but mostly looking at the motor symptoms or the shaking, at the walking, in a very artificial setting. This is a very cold and room where most of the time our patients are not at their best comfort. And in a random point in the medication cycle, we know the patient with Parkinson take the medication 2, 3, 4 times a day, and they may have an on phase, an off phase. And the time they show up in the clinic is very difficult to predict. So we're really observing a very, very random moment in their life. And still, we make decisions. We make sometimes important decisions, changing of the medication, changes of certain patterns based on incredibly incomplete information. And that goes on top of what is already a very, very difficult situation for patients with Parkinson's disease that have access to a specialist in movement disorder only in less than 10% of cases in the United States. You might know that the majority of patients with Parkinson's disease see a general neurologist at best, and sometimes not even a neurologist, like a primary care provider, like an internist. And only 9% of cases, they see a specialist in Parkinson's disease. So here we have in almost 40% or more, almost half of the cases, you're going to see a patient, a doctor who's not specialized in Parkinson's disease, but in 20 minutes has to figure out what to do for the next 6 months. I don't need to explain to you how inadequate is the way we take care of patients with chronic disorders and Parkinson in particular. So how does digital monitoring system, how is technology can help us? Well, there are a number of gaps, and they can all benefit. So for example, temporal gap, like we see a patient every 6 months, and we have really no idea. We rely on memory that sometimes is not very sharp to figure out what happened in between visits. The digital data can give us continuous, right, data with much more details, much more granularity. The observation or even the recount of patients can be very subjective, while the digital data obviously can give us quantitative metrics, can give us data that is contemporary, like it's being taken on that specific day at that specific time. It can therefore help us with the fluctuations of the symptoms during the day, not just based on recall of how much time I was off or on, but we can measure that. We'll see which devices can actually help us with that. We can evaluate gait and fall risk. We never see falls, of course, in the clinic. It's absolutely rare, fortunately. But we have to base our decision on the recall of patients or family members that well, I fell 2, 3 times. It's very approximative. The cognitive part and the non-motor part, all the other organs, the urination, the constipation, the blood pressure is poorly captured. Sometimes it's not even asked about, while this biomarker, especially with sleep, can definitely help tremendously in collecting all this data. Parkinson's disease has many different phenotypes or manifestations that are not almost considered at all during the visits, while these devices can give us information, more tremor, less tremor, more gait problems, less gait problems. So the clinical decisions that are reactive, they're based on what happened in that moment, more or less. So what our patients tell us on incomplete data, as I said several times, can be data-driven, can be driven on objective information and not on the moment, the recall of the moment. Then the clinical trials, which obviously is a different level of intervention, can also be much more accurate in the evaluation that sometimes might lead to abandon medications that could be effective just because the evaluation was incomplete or based on insufficient data. So you see how many domains, how many parts of the puzzle can be helped using digital monitoring. So here's sort of a a synoptic view with all the different domain and the digital solutions. So we have clinically validated wearables. We'll look at them one by one briefly. We have consumer wearables, something that we can buy like at the store, literally like an Apple Watch or a ring. And then we have some specific apps, and we'll spend some time on an app that we are developing and at Cedars-Sinai. It's called the New Health app, which are specifically designed to sort of include all this information and create a summary state of the art, state of the situation for every specific patient. So let's look at them a little bit. So what is the idea here? The idea is that you have this wearables, a smartphone, sometimes data that is reported by the patient with specific prompts that brings this digital biomarker, for example, sleep cycles or shaking, how much tremor, how much gait instability, how many falls happen during the period, that can then inform the clinical decision of the provider, of the clinician. So a pretty simple concept. Let's see how this is implemented. There we go. So we have a number of systems. We have the PKG, the personal kinetic graph, the kinesia, the PD monitor, Staton, FitMe. These are all specific systems that I will review with you. Some of you might be familiar with some of them. The first is the PKG, which looks, you can see it looks like a watch, literally. You can put it at your wrist, and it measures, it has an accelerometer. It has some the ability to detect movements or abnormal movements. So it can track slow movements, bradykinesia, dyskinesia, tremors, on and off state fluctuations, the ability, the compliance with the medications, because there are buttons and reminders for the exact time for the medication. You can wear it for a number of days continuously, and it generates, you see it here in the bottom, this very, very detailed reports, which you see they include hour by hour measurements of movements and tremors, and it can really give the clinician the idea of how well the medication is working and for how long it's working in case of wearing off. It's widely adopted, it's FDA approved, and the possible limitation is that it focuses only on the motor part of the disease, so the speed of movement, the dyskinesias, it's a relatively limited info about the gait, and often, at least in our experience, it might confuse active exercise with dyskinesias. We tested this at Cedars-Sinai a few years ago. We published a paper with my colleague, Dr. Tan and Dr. Hogg, and we found it actually helpful to, for example, to differentiate early versus troublesome fluctuators. So those who did not need too much attention versus those who we needed to intervene with changes in medications or maybe deep brain stimulation. Dyskinetic versus non-dyskinetic subjects, with the possible exception of those who were exercising actively every day. And we were able to distinguish people with dyskinesias in non-fluctuator, moderate fluctuator, troublesome fluctuator. So a concept that can be useful to make decisions and alleviate these problems in our patients. Another system is the kinesia system. It's also been used for many years now. And he has, instead of just the wrist sensor, also you can put an ankle sensor, so it has more information about the gait. And in fact, it can monitor tremor, dyskinesia, bradykinesia, body position, activity. And you can almost have something similar to the UPDRS, the scale that we use in the clinic to evaluate the overall severity of the disease. It's very good resolution in detecting motor problems, but it's less sensitive to other problems like rigidity or posture that can be the main problem in some of our patients. Another one is the PD monitor, which, as you can see, is even more complex. It has the wrist sensor, a leg sensor, and a waist sensor. So it can give you also an idea of posture, balance, freezing of gait, in addition to the other typical symptom of Parkinson's disease. It can generate very detailed reports every half hour, very, very comprehensive, but a little bit more complex, a little bit less practical, right? You have to wear all these sensors. It's not always easy to go around with all these sensors in your body. STAT-on is another one another device that is very, very focused on gait. In fact, he has a single waist sensor that gives very, very good information on gait, freezing, falls, frequency, severity, when patient is off and on, is used in many clinical trials that are focused on freezing of gait. Of course, simpler than the multi-sensor systems, but by default, it has less information about hands, about upper limb data that can be important for some patients. Last but not least, we're going, as you see, more and more toward the lower limbs. It's the FitMe, which is a sensor which is actually in the insoles, so literally in your shoes, and can give very, very detailed information about walking, cadence, stride, pressure, freezing of gait. Very, very good, probably clinical trial level analytics and data, but it's pretty much limited to the gait. Obviously, if that is what we want to analyze and figure out, that's ideal, but then we will lose many other type of information. As I mentioned, there are then consumer wearables, something that we can literally buy online or wherever we buy our devices. And you see, you can monitor several health metrics. They're not specific for Parkinson's disease, but very, very powerful if you pair them with dedicated apps that can put together this information in relationship to the problems that we know affect Parkinson's disease. Some of them are very popular, very well known, like the Apple Watch, for example. They can detect tremors, they can detect sleep patterns, they can detect also gait stability, can detect falls. And in fact, the Apple Watch is used in large-scale Parkinson's disease-related studies, also because of it's so popular and easy to use. Similar to the Apple Watch is the Fitbit, it's the Garmin, which can also monitor activity and sleep, less used specifically for Parkinson's disease. Another very popular is the Ring, the Oura Ring. You can see many people these days going around with this fancy rings that check their sleep, their autonomic metrics, can be very helpful in some instances with Parkinson's disease. And then there are the Parkinson-specific mobile apps, so apps that are designed specifically to focus and collect and analyze data that can be critical to monitor the progression of Parkinson's disease. and it can be paired with the wearables. It can be using, as you will see, the smartphone itself as a tool. But these are sort of the ultimate evolution, right? The specific Parkinson dedicated mobile app. Strive PD is very, very popular. And it couples the iPhone and the Apple Watch. They're integrated. You can track tremor, dyskinesias, timing of the medications. You can even associate it to deep brain stimulation programming. Very, very widely used and successfully used. And then New Health. I'm going to spend a little bit more time on New Health because we are piloting this app at Cedars-Sinai. Disclosure, Cedars-Sinai has an interest in this app. I personally have no conflicts, no personal conflicts, but I just wanted to make sure that we know this relationship. So New Health is a smartphone-based platform that can monitor the progression of the disease. It's not primarily wearables, similar to Stripe PD, but there is an evolution. We're probably going to add on some wearables also to New Health. And the interesting thing is that it combines the app, the patient manipulated app, a dashboard that the clinician can access on the electronic medical record. So this data is not sitting on some laptop or some cloud system, but it goes straight and privately to the patient chart, basically. And then there is an AI-driven function that can analyze the incredible number of data that we can collect. I'll show you some number later. So we use the phone as a sensor, and we use these short tasks, which I'm going to go through one by one briefly, and also some passive phone interaction. So we have a motor assessment. You see, one of the problems with the previous devices that they were either only motor, only gait. Here we're trying to have a much more comprehensive approach. So motor assessment, tremor, balance, gait, dexterity, voice, but also cognitive, memory, processing speed, executive function. And we have a function which patients can report what is going on, what is their worst symptom, for example, or they can put in how many hours they slept, whether they're anxious, depressed, whether they're in pain. They can put in a blood pressure measurement, and they can check their, we can check their compliance with the medication. So a little bit more comprehensive approach. This is how we look at the motor tests. You see, there are 7 tests. The first one is going to check the voice. So we're going to have basically the patient voice into the phone, and the phone can record the specific features of the voice, intensity and duration of the vocalization. Then there is a balance test, very simple. You basically stand straight with the phone in your hand. The gait, you can put the phone in your task and then walk up and down 20 yards, and it will give us information about stability and cadence and stride length. Then there is a little exercise with tapping, which will check mobility and dexterity, reaction time, resting tremor, holding the phone in the hand at rest, and postural tremor, holding the phone in the hand outstretched. This takes probably 5 to 7 minutes, about a minute each, so it doesn't take too much of the daytime. Then we have 3 cognitive tests, 3 visual cognitive tests. There is a processing speed test, an executive function, following a trail, and a little memory test, trying to recall what objects were on the screen. These can be challenging if there is a cognitive decline, and that being associated pretty significantly to diagnosis of mild cognitive impairment or even Alzheimer's disease in other contexts. So in their simplicity, these tests are quite indicative of initial cognitive decline. So how does it work in the real world? So patients are enrolled usually during a routine clinical encounter. We offer them the opportunity to sign up and set up. We have one of our PIs that explain them what is the number of tests and what is required to them. So then that they go home and they start performing this motor and cognitive testing regularly, every day, every other day, depending on how much they want to commit to the system, input symptoms, blood pressure, sleep information, etc. And this is the nice thing, at least the new and in my mind revolutionary thing. Every month we have this is one of our PA that calls patients to give them feedback, real-time feedback. So looking at the reports that are generated by AI on the app, we can basically tell our patients whether they're doing well, that whether we see something declining or improving, maybe whether they need to change medication. I'll show you later some vignettes of how the app can be used. There are two centers in the United States. One is us at Cedars-Sinai, the other is Mass General, that are currently using the app. In England, where this was designed, there are 11 NHS hospitals that have been using. And so this is just an idea of what can happen by checking patients every month instead of seeing them every 6 months routinely. We can intercept problem before the patient is due for the next visit. And during the visit, the neurologist doesn't have to rely on the memory of patients or caregivers or family members, but has a trove of information, fortunately summarized by AI synthesis, to make decisions and make changes if needed that are based on real-time data and not on some spotty information. This is some of the data. We have currently 150 patients that are enrolled. We have about 3 out of 4 patients are interested and sign up, more or less the same between male, female, with a large range of ages, as you would expect in Parkinson's disease. You see the sort of continuous increase of our number of patients and the age distribution. And we have this data. You see medication enlargement, symptoms, sleep event, etc. So look at these numbers here. In the first 6 months, we collected over 37,000 data points. You see the need for AI summaries to analyze this incredible amount of data. But we have not just data collection, we have signals that can be actionable, because we have pattern of symptoms that emerge: fatigue, stiffness, sleep difficulty. Every patient may have their own set of symptoms, and we can specifically act on what bothers them the most or what the app is signaling to us. And then this is data courtesy of Dr. Mohammed from London. This is data analysis that have been carried out in England, where they have more experience, as I said. And there is a very interesting correlation between the tests that I just showed you before, the tremors, the gait, the balance, and the UPDRS, and the scale that the clinician would use to evaluate the severity of the disease. So we can have a almost equivalent UPDRS done almost every day or multiple times a day as needed. And most importantly, this is the thing that is most interesting in my opinion. machine learning is starting to estimate models of risk. So based on the information that this test bring in, we can estimate, the system can estimate who is at risk, for example, for falling, which is one of the most important, severe, devastating possible complications of Parkinson's disease. And initial data seems to confirm that, for example, patient at a small, average, or high risk of falling, indeed, over a period of time, tend to fall less if they have a small risk, or more if they have a higher risk. So we can intercept this type of risk before, and not just react to them once the patients or the family let us know that there's been a fall, sometimes possibly with physical consequences. So let's see a few scenarios. How can we use it? So this is for example, a patient that has Parkinson's disease in early 50s, and we look at the app, and we see that the gait seems to have deteriorated over time. And this is something that we might learn, if at all, maybe months later, weeks or months later. But because we have this monthly calls, our PA noticed this trend and can start asking questions to our patients, and maybe recommend physical therapy, or maybe discuss with the clinician whether maybe the levodopa dose needs to be changed. And so instead of reacting to a fall, we can intercept the risk for falling and try to prevent this. So we're going from reactive medicine to preventive medicine. This is a different story, but still a nice application of this type of systems. Here we have a patient that has a tremor. Usually the tremor in Parkinson is more on one hand than the other. So the right hand shakes more, improves every time it takes the medication. But then it looks like in the evening, the tremor seems to get worse for some reason. And the PA explores the fact that in the evening, the medication is taken at dinner time, it's taken with the meal. And so that might interfere with the absorption of the medication, and therefore with the potential benefit. And so we can give this type of advice in between visits, not waiting for the patient to come to the regular follow-up. This is another case, a patient with that doesn't speak fluent English, so there is a language barrier and maybe also cultural barriers. So she's not reporting that she had bladder problems during the regular visit. But in the app, she does note that the bladder symptoms is one problem, and also that her sleep is affected by these problems with the bladder, causing, for example, her to wake up many times during the night. And this is something that maybe would have never been caught during a regular visit, during the regular 15, 20 minutes visit, just because of the language barrier. And instead, the app can allow us to, again, intercept and prevent the problem. Last but not least, many times patients are seen several months apart. And if the symptom is not brought up to the attention of the neurologist, it may never be even addressed. And however, if the patient starts putting in the app that the main problem, or one of the main problems, is memory in this case, we can spot it, and we can start working on preventive measures like improving sleep patterns, or reducing medications that can affect cognitions, and so on. So clinicians like the app enables earlier clinical review, improve the efficiency of the consultation, because we have much of the information already available. And so there is less sort of digging and asking and trying to figure out what happened in the last 6 months. And so the clinical understanding of what is the main problem in these patients and the trends in what is, after all, a progressive disorder are easier to identify. And patients, obviously, they like the ability to be followed more often. They find the app relatively easy to use, and this is a nice fact. In almost three-quarter of them would recommend it to a friends. And beyond these nice testimonials, we find many patients to truly find it extremely helpful as a companion in between visits. This is a study that comes from England, and you see all these percentages. I want to direct your attention to the bottom, which is, I think, very, very interesting set of data. You see the reduced emergency demand. So there was a 1.2% reduction in emergency admission, so in visit to the emergency room, as compared to an increase of almost 9% national increase in patients with Parkinson. This is, if it's confirmed, we are obviously starting to work on this data, is a tremendous outcome, reducing the visits to emergency room and therefore eventual admissions for accidents, trauma, falls that could have been otherwise prevented. These are some of the initial experience. You see that the physicians found that they could intervene earlier, that be more proactive in medication changes, not just reactive, reduce clinic time, and reduce emergency admissions. The patients found it easy to use, would recommend to a friends. About 60% found it able to use it every day, and 20% found self-empowered. They found more in control of their disease. So what are the pros and the cons? We are almost to the end. The new health has no dedicated hardware required. So you don't need a specific watch, a specific monitor. So it's a lower barrier. You have to buy less gadgets. It's more scalable. It combines, this in my mind is probably the most interesting aspect, motor, cognitive, and speech tracking. And so it's much more able to give us a full picture of the Parkinson presentation. We are using it to have between visit information and intelligence, so detect the deterioration early before the accidents and the problems might occur, and therefore guide the clinical the decisions. So we can measure not just the movements as the wearables do, to our entire function is a global assessment of motor, speech, cognition, and behavior, with the possible limitation that it require to be onboarded on their chart and on the physician dashboard. So it's a little bit more complex than just looking at your Apple Watch and see how you slept the night before. So it's not fully passive. You have to include certain data. You have to input certain data, and we still it's still evolving. It's still something that probably we have not seen the last reiteration. And this is just my vision based on what we discussed. So we want to go to a future in the Parkinson Clinic where continuous monitoring remotely replaced or maybe integrates episodic visits at the doctor's office with pre-visit dashboard that summarize these problems, so that the physician doesn't have to interrogate a patient that many times have maybe initial cognitive dysfunction to learn, but they already have the data and can spend the time implementing solutions or strategies. Artificial intelligence driven alerts that can tell us on time, not just during the visit, if there is a deterioration or complication that needs intervention, in-person and virtual optimization, so continuous monitoring, personalized therapy, integration of the wearable, the smartphone, and the electronic medical records. And so ultimately the shift from a reactive care to a proactive, predictive, and hopefully preventive type of neurologist. And this was my last slides. I want to thank our wonderful team at Cedars-Sinai. All of our attendings are involved in this project and recruit patients to test this digital monitoring project. Thank you for your attention.
Thank you so much, Dr. Tagliati. So if you have a few minutes, we do have a few questions that have come in. Going back to the earlier part of your presentation when you were reviewing some of the other technology or devices that are available, we had a question if any of those were, to your knowledge, covered by Medicare.
Good question. I am not sure that Medicare covers commercial devices or even specifically device, but I have to confess there is some form of, probably for the PKG and the kinesia, there is some consideration for the from the insurance. For the one we are working on at this stage, we are providing, basically we pay the device licensing, and so we give it for free to our patients. There may be insurance a charge for the monitoring visits, for the regular monitoring visits, which however they're not like regular visits, they're pretty quick and inexpensive in most cases. But I believe that the apps that are FDA approved might also have specific codes for Medicare or insurance. So not the commercial wearables, but the PD Act, like PKG and kinesia. I'm sorry, I'm not more precise, but I believe that there is a level of coverage.
Along that line, someone wanted to know of the devices that are currently available to the majority, which ones would be the best choice for tracking and monitoring tremors and dyskinesia?
So there are many of them. As I said, I have personal experience with the PKG, and that was very, very effective. The kinesia is very effective. I think even the Apple Watch as a good tremor. Everything that has an accelerometer and at the wrist can be used. Sometimes it's not easy to go around, right, with this gadgets around your wrist, especially if you're still working and you don't want to disclose what's going on, and it can be a little bit intrusive, right, in your social presentation, for lack of a better term. But there are more than one of them that can be used to detect and to monitor or to measure abnormal movements.
So are any of those ones that they have the accelerometer on it, are they good for essential tremor patients as well as Parkinson's?
Yeah,
Can it
tremors,
be
yeah.
applied?
Tremor, absolutely. It's a different frequency and intensity of oscillations, but the device will be sensitive to any kind of oscillation. Then essential tremor is not very different often than Parkinson tremor. It can be very similar. It can be very difficult to distinguish unless you have other information like the rigidity, the bradykinesia, the sleep problems that define the Parkinsonian presentation. But the tremor per se sometimes can be virtually impossible to distinguish between the two.
If anyone lives in your area, or if maybe outside, are you recruiting additional patients for your research? And can they be out of state? Or do they need to be local to you?
Very good question. So unfortunately, we cannot practice medicine out of state. So at this stage, our pilot is limited to patients that in somehow they're in the Cedars-Sinai system. Because the problem is, as long as you're here in LA, you can come from Arizona and you come here, we can definitely do that. But the advantage of the monitoring is that we can then call you at home. You don't need to come here every month. And so if you then live in another state, we cannot call you and for all practical purposes, practice medicine, change the medication while you're in another state. So these are limitations. We have, for example, international patients that have been trying to recruit, and we had some difficulty from a regulatory standpoint at this stage.
So we also had a question, do you see any potential for pairing digital monitoring measures with diet, exercise, sleep recommendations that are tailored to the individual patient and their mobility and disease stage?
The answer is an enthusiastic yes. How and when we will be able to do that with sufficient precision to be meaningful, that's obviously all to be studied and designed and decided. But the ultimate goal is to have a holistic approach to the patient with Parkinson's disease, not just measure their tremor, the dyskinesias, or the response to medication, which obviously is very important, but it's not the only story. So definitely nutrition, sleep is probably one of the most important variables in the well-being of our patients. Again, cognitive, blood pressure, there are so many variables that we can eventually integrate, and thanks to the ability of machine learning and AI to summarize, to analyze this data, produce risk models, and really focus on those patients that seems to be closer to getting trouble, so to speak, and really try to prevent these evolutions.
You mentioned cognition, but is mood a consideration too? People that are maybe dealing with depression or anxiety or even just apathy, is that something that can be added or measured?
Absolutely. For example, the app that I just described allows you to indicate. So it's difficult to measure anxiety with a wearable app, right? But we have the option of indicate my worst problem is, for example, anxiety or depression, and that comes on the top of the list and immediately alert the physician, the clinician that that is something that needs to be addressed. Otherwise, it may be the 19th question that we ask during the visit. But if the patient consistently put it on the top, that becomes the first question during the visit, and it gets immediately addressed, hopefully to the satisfaction of our patients.
So we also had a question. Which digital metrics do you feel would be most helpful to track changes in people who are at risk for Parkinson's but may not have yet phenoconverted?
That's a very good question, and it's something that as I premised, I was not addressing in this presentation, but the problem of phenoconversion in patients that are at risk, usually patients that have REM behavior disorder plus possibly other premotor symptoms like loss of smell or constipation or anxiety and depression. has to do probably on what we call autonomic function. So definitely blood pressure, heart rate variability, sleep patterns. It is not clear, even though I happen to be among those who study this premotor phases. It's really not clear which one is the predictive. We don't have a clear predictive path to phenoconversion. The phenoconversion seems to happen anytime between 3 years to 20 years after developing, for example, REM behavior disorders. And although there are some criteria, you know, if you have autonomic dysfunction, meaning blood pressure variability, for example, or constipation, it seems to potentially accelerate or be a symptom of acceleration. But there is not, at least in my mind, a very clear paradigm. So we would have to probably initially devise a system in which the patient can inform us of certain situations. It's difficult to digitally monitor constipation or smell. Would also require some testing, and which can probably be envisioned at the digital level, but definitely would require some technological advance. But those are the symptoms that would have to be a monitor. And if there is a worsening in those symptoms, that would tell us that the neurodegeneration or whatever is going on is going closer to the symptomatic, the neurological expression of it. Is a system in flux. I mean, I'm not aware of wearables that tell us the risk of phenoconversion, but that's definitely where we're going.
Awesome. Well, I know we're close to the end of our time, so I want to thank you so much for sharing this. This is exciting, a lot of exciting stuff coming down the road, and I'm looking forward to an update from you when you have done even more research with this and when it might be widely available.
And thank you for having me. And this question actually are very important to me, because I like to listen and then go back to work and try to provide those answers, not just intellectually or with the hope, but really with concrete tools to measure all these aspects of neurodegeneration or risk toward the neurodegeneration. Thank you again for having me again.
Thank you. And thanks everyone for joining us today. And again, if you are interested and you're someone who falls in that category of being at risk, preclinical prodromal, we do have, like I said earlier, if you missed it, July 22nd, we have our Space Between program. And then our next Connect group, our support group is it's called At Risk Prodromal Connect, is July 8th. And so you can find those on the Proactive Brain Health Alliance website, which the link was dropped earlier. So you might want to save your chat. And you can also find it through the PMD Alliance website. You can get to the Proactive Brain Health Alliance site from there as well under resources. So thank you again, Dr. Tagliati. We're so appreciative of your time and your expertise. Can't wait to hear more about this.
Thank you for having me.
Thank you. Bye.
Bye-bye.